Alrighty, let's talk about corneal abrasion. As you can see in this picture, this is a corneal abrasion with fluorescein staining. We usually need to diagnose it applying fluorescein on it, as the abrasion will uptake the fluorescein. But before that, we need to talk about the symptoms. Then we're going to talk about the signs, differentials, workup, treatment, and lastly, follow up. So, for the symptoms, the patient will come with sharp pain, photophobia, foreign body sensation, tearing, discomfort with blinking, history of scratching or hitting the eye. The signs, as we saw in that picture, you should do fluorescein and the epithelial defect will stain. Absence of underlying corneal opacification, because presence of that could indicate infection or inflammation. These are the critical signs. There are other signs as well, like conj injection, swollen lids, mild AC reaction. Okay, what are the differential diagnoses? So we talked about the symptoms, we talked about the signs. Differential diagnosis could include other causes for this. For example, recurrent erosion. That could be another differential that we should keep in mind. Herpes simplex keratitis and confluent SPK, which is superficial punctate keratopathy. Now, let's talk about the workup. How do you deal with this patient? Well, you should do a slit lamp exam, obviously with fluorescein, and you should also evert the eyes. And I'll talk about why in a minute. Now, as you can see here in this picture, you can see that the abrasion is taking up the fluorescein. So you should measure the size, the height, the width of the abrasion, and you should diagram its location and evaluate for an AC reaction, infiltrate, underlying corneal opacification, corneal laceration, and penetrating trauma. Okay, this is for the slit lamp exam and what you should check for. Now you should also evert the eyelids. Why? Because you want to make sure there's no foreign body, especially in the presence of a vertical or linear abrasion, like in this picture here. Now, we talked about the workup. How do you treat such patients? Well, first of all, you should give antibiotics. Now, it differs from contact lens wearer to non-contact lens wearer. If the patient wears contact lens, you should give anti-pseudomonas coverage antibiotic, either ointment or drops, at least QID. If the patient does not wear contact lens, you could give the patient ointment, for example, erythromycin, bacitracin, or bacitracin polymyxin B, Q2 to 4 hours, or even drops, polymyxin B, trimethoprim, or a fluoroquinolone QID. Now, if this abrasion is secondary to fingernail or vegetable matter, you should cover it with a fluoroquinolone drop, like Cipro or Moxie, or ointment like Cipro, at least QID. Okay, now, to use drops or to use ointment, it depends on the patient. Ointments offer better barrier and lubricating function between the lids and the abrasion, but it tends to blur the vision temporarily. So it depends on the patient. You could also use cycloplegic agent like cyclopentolate, BID or TID, for traumatic iritis, which may develop 24 to 72 hours after the trauma. And here's a picture of a typical traumatic iritis. Now, if the patient has iritis, you should avoid steroids because this will hinder the epithelial healing and will increase the risk of infection. For small abrasion, you should avoid using long-acting cycloplegics to allow faster visual recovery. Now, do you patch the patient? Well, it's rarely necessary, maybe for comfort, but you should never patch the patient if the mechanism of injury involves vegetable matter, fingernails, or if the patient wears contact lenses. When you place the patch, make sure that it's properly placed so that the upper lid is totally prevented from opening, because this could cause serious abrasion. Now, you could give the patient topical NSAID drops for pain control. Um, Avoid this in patients with other ocular surface disease and in post-op patients. Oral pain medication can also be used for pain control, even narcotics if in severe cases. If there's loose or hanging epithelial, you should debride this because this will inhibit the healing. A cotton-tipped applicator soaked in anesthesia, for example, proparacaine, or a sterile fine forceps could be used, but obviously use it with caution. No contact lens wear. Um, so some clinicians they bandage contact lens for therapy, but it is rarely done so unless the size of the abrasion and discomfort justifies it, and there is poor healing, and of course there's no infection. Then you could use a contact lens. If a bandage contact lens is used, you should give the patient prophylactic topical antibiotics. For example, polymyxin B trimethoprim or fluoroquinolones QID. And you should follow up the patient daily for evaluation and contact lens replacement. Now, we finished with the treatment. Now, let's talk about the follow-up of the patients. You have contact lens wearer and non-contact lens wearer. If the patient is a non-contact lens wearer, he should return in 24 hours, or for both cases, if he wears contact lens or if he doesn't, if the symptoms worsen, he should come back sooner. Okay, and you should instruct the patient that. Now, if there is central or a large corneal abrasion, or if there's small abrasion. If there's a large abrasion, you should return the next day to determine if the epithelial is improving or not and it's healing or not. You may see the patient 2 to 3 days later. Instruct the patient to return sooner if the symptoms worsen. Like we mentioned earlier, revisit every 3 to 5 days until it is healed. Now, if there's a smaller abrasion, the patient could return 2 to 5 days later. And if the patient is a contact lens wearer, he should have close follow-up till the defect is resolved. Then you treat the patient with topical fluoroquinolone or tobramycin drops for an additional 1 or 2 days. The patient can start using his contact lens again after the eye feels normal for a week after stopping the course of drugs, and a new contact lens should be started for the patient. That is it. Thank you very much.